Good evening. On behalf of the president and founder of Black Health Matters, Rosalind Young Daniels, and the entire Black Health Matters family, I would like to extend a warm welcome to everyone here this evening. I am Nicole Adams. Tonight's program is supported by an educational grant from Novo Nordisk and brought to you in partnership with the Academy for Continued Healthcare Learning, whose mission is to design, develop, and implement quality educational activities that have a positive influence on the way healthcare is practiced and improve the quality of care provided to patients. For this online discussion, you are in listen only mode. At the conclusion of the presentation, the Q&A will open for you to submit confidential questions. Following our event, resources will be made available for anyone that would like more information. Do you have the heart? Arm yourself against diabetes and cardiovascular risk. Our faculty presenter for this program is endocrinologist Dr. Salimi Y. Fahmy. Dr. Fahmy is a solo practicing endocrinologist at Endocrinology Associates of Southwest Dallas in Texas. Dr. Fahmy earned her medical degree at New York University School of Medicine. She completed her residency in internal medicine and fellowship in endocrinology at the University of Texas Southwestern Medical Center in Dallas. Dr. Fahmy was board certified in internal medicine endocrinology in 2007. Upon completing her fellowship, Dr. Fahmy established her own practice in the community where she was raised. The high prevalence of obesity and diabetes has motivated her to remain in Southern Dallas to continue her work. She has a special interest in the treatment of childhood obesity, the detection of early diabetes, and the prevention of diabetes in at-risk youth and young adults. She believes that education, empowerment, and early intervention are crucial to decreasing the prevalence of diabetes. Dr. Fahmy has authored or co-authored articles published in such peer-reviewed journals as Human Molecular Genetics, Clinical Diabetes, and the Journal of Clinical Rheumatology. Through her work at her practice and in the community, Dr. Fahmy strives to have a positive impact on as many people as she can. Welcome, Dr. Fahmy. The floor is yours.
Thank you for having me, Ms. Nicole. I appreciate the opportunity to be able to give this presentation. Hopefully it will be impactful to many people abroad listening in. So, do you have the heart? Arm yourself against diabetes and cardiovascular risk. So, this is supported is by an educational grant by Novo Nordisk. Providership, the Academy for Continued Healthcare Learning has partnered with Black Health Matters to bring you this education. So the learning objectives for this evening: understanding type 2 diabetes, the related risk of heart attack and stroke, to discuss the importance of addressing cardiometabolic factors in addition to glycemic control and to reduce risk, and describe how early benefits of some therapies, including glucagon-like peptide receptor agonists, can have benefits for cardiovascular risk. So what we're going to talk about tonight: so what is type 2 diabetes and what are its complications? What is cardiovascular disease or CVD? What lifestyle changes and medications can help you reduce your risk, your cardiovascular risk? And how should you talk to your doctor about reducing cardiovascular risk, and what questions should you ask? So what should you know about type 2 diabetes? So what do African Americans say about diabetes? These are a couple of quotes. I had great aunts who had amputations. When I was a kid, they would always say they had sugar, and so I thought it came from sugar. Certain things about diabetes have been explained, but I feel like there's more to know. So as the quote says, there's always more to know. I recently just had a very close family member ask me to help them go through their blood work, and they saw that their blood sugar was elevated. It was 109. And I told her that because it was fasting, that was a little bit high. And I went on to explain to her that when the blood sugar is elevated, that's an issue. It should be below 100 for all comers. That's what's considered normal. And so, well, she says, does this mean that I'm borderline? And I was like, yeah, in part, this is a part of the reason that you're borderline. And she went on to say, about how she didn't eat a lot of sugar and she didn't understand why the sugar was elevated. But then I went on to explain that sugar doesn't just come from sweet things. It comes from any type of carbohydrate, any starch. And so I explained it's not just, the bread, the rice, the pasta, the corn. I said it's also fruit. And she was taken aback because she says, well, I thought that fruit was healthy. And I was like, well, fruit is always sweet, right? And so and so she understood that, okay, the sugar, even though it's coming from fruit, it's still sugar. It's going to come from starches. So that's going to mean bread, pasta, corn, peas. It's going to come from any fruit, bananas, oranges, apples. It can come from any other type of starch. So looking at baked goods, crackers, cookies, cereals, hot cereals, cold cereals, all those things are starches, and eventually they're broken down to glucose. So what is type 2 diabetes? With type 2 diabetes, glucose or sugar from the foods that you eat, it enters into the blood. So remember, the sugar is not just from sweet things. It's from any type of starch, any carbohydrate. It's going to be eventually be broken down into sugar. And so diabetes, you have an increased blood glucose, and when this happens, it signals the pancreas to release insulin. So insulin is released. And type 2 diabetes, and that's the main focus of today's discussion, is type 2 diabetes. The cells do not respond well to insulin. And this is what we call insulin resistance. The cells don't respond well. And so instead of the sugar going into the cells from the bloodstream, it stays in the bloodstream and the blood glucose stays elevated. So that's what we go from, where we go from borderline diabetes, so just minimal elevations, to full-blown diabetes, which is going to be more significant elevations, to uncontrolled diabetes, which is going to be dangerous or risky elevations. So did you know prediabetes is when the glucose levels are higher than normal, but not quite enough to be diagnosed as type 2 diabetes? So this is actually the time to intervene. And in all honesty, it's time to intervene even before we have prediabetes. Even if you have risk factors, if you have, parents that have type 2 diabetes, siblings, aunts, uncles, if you're overweight, these are all the times that we want to go ahead and intervene, because we know that once you get prediabetes, diabetes is right there, coming right after it, unless we make some intervention. So weight loss, exercise, and changes in your diet can really prevent prediabetes from becoming type 2 diabetes, and it can prevent being predisposed to having prediabetes from even getting to prediabetes if we really do intervene early in that process. So what test results are used to diagnose type 2 diabetes and help guide control of the disease? So blood glucose, or hemoglobin A1C, you'll hear that term a lot, ranges for type 2 diabetes. So there's a normal blood glucose is going to be less than 100, as I said. Pre-diabetes is going to be from 100 to 125. And this is fasting. So fasting is when you first wake up in the morning before you've had anything to eat or drink, unless it's just been water. So typically the fasting blood sugar for most people is going to be the lowest blood glucose of the blood sugar of the whole day. So pre-diabetes is going to be anywhere from 100 to 125. So again, a little bit above normal, not quite in the diabetic range. Diabetes is going to be greater than or equal to 126. And so when you're looking at that hemoglobin A1C, what is hemoglobin A1C? So you hear that word hemoglobin, we know that hemoglobin means blood. So the hemoglobin A1C is calculated actually by looking at the sugar that's actually deposited onto the red blood cells. The red blood cells live for about 3 months in the bloodstream. And so when you look at that hemoglobin A1C, that hemoglobin A1C really reflects the average blood glucose over the previous 3 months. That's why typically it's recommended that if you do have diabetes, you're going to go to your doctor every 3 months. You're going to get that hemoglobin A1C, because that hemoglobin A1C reflects the blood glucose over those previous 3 months. So looking at the A1C, a normal hemoglobin A1C is going to be 5.6 or lower. Pre-diabetes is going to be 5.6 to 6.4, and diabetes is going to be greater than or equal to 6.5. And whether or not the diabetes is controlled really just depends on the guidelines. But typically, if you're above 6.5, if you're above 7, that's going to be what we consider uncontrolled diabetes. So blood glucose ranges for patients with type 2 diabetes before eating while fasting is going to be being greater than 130. That's too high. That's too high for most people. Sometimes as patients get older, and they may be a little bit more risk, we do let these guidelines kind of change a little bit, but that's for much older patients. I'm talking about patients that are in their 80s and 90s even. It's recommended typically between 80 and 130, and less than 70 is going to be considered too low for most patients. So why is controlling blood glucose important? So over time, we know that the high blood glucose can lead to chronic kidney disease. We all know about this. This is what we call nephropathy. This is what leads to dialysis. Diabetes is still one of the leading causes of kidney failure and the need for dialysis in this country. Nerve damages or neuropathy. We've all heard about this. People, they can't feel their feet, they can't feel their toes, things like that. This is neuropathy. This is damage from the nerves because those little small blood vessels feed those little small nerves. And when those little small blood vessels are damaged because of the high glucose, they can't feed those little nerves, and those nerves get damaged and it develops neuropathy. Erectile dysfunction. This is a big one. This is one that many people don't think about. So for all you men out there, controlling the diabetes is going to be key to keeping all organs functioning normally. Erectile dysfunction is a big issue when it comes to diabetes and uncontrolled diabetes, especially. Peripheral vascular disease or PVD and amputations. Again, those blood vessels are damaged. They're not getting good blood flow. An infection can come in, the body cannot clear it out, and this leads to amputations. Eye disease, retinopathy, blindness. Again, type 2 diabetes, one of the leading causes of blindness in this country. And then cardiovascular disease. Cardiovascular disease is a big one. I always tell my patients that diabetics, they don't die specifically from elevated blood glucose or blood sugar. They typically are going to die from strokes and heart attacks. Those are the things that we think about. Those are the things that are going to lead to their demise. And so it really should be the focus of controlling the diabetes and keeping that risk lower. So type 2 diabetes is more common and has more severe consequences in African Americans. So this is compared to non-Hispanic whites and non-Hispanic blacks. 80% more likely to be diagnosed with diabetes, twice as likely to die from diabetes or its complications, 2.5 times more likely to be hospitalized with diabetes and its long-term complications, and 3.2 times more likely to be diagnosed with end-stage kidney disease. Again, diabetes is a leading cause of patients that end up needing dialysis and transplants. So, what do African American patients say about controlling their type 2 diabetes? It's an adjustment where you have to check sugar, watch what you eat, and balance out the medication to make sure you're okay. Some of my friends say, see what I eat, and then they say, well, I should have what you're having. Maybe hanging around you will make me pick up better habits. Weight loss comes up a lot. Every single one of my doctors told me to lose between 30 and 35 pounds. All of these quotes are really talking about lifestyle modifications. Lifestyle modifications are key to diabetes and controlling diabetes and preventing all those complications. And so what you eat, how much physical activity you have in your day, all these things really do come into play when it comes to controlling your diabetes. And it's true, when people are around other people who may have good eating habits, sometimes that will rub off. And if you have friends that exercise, maybe you will be more likely to exercise and just have a better lifestyle. So how can you control your blood sugar? So again, exercise, medication, diet changes, weight loss, and then checking your blood glucose. When you know what your blood glucose is, you're going to be more likely to respond. And we all know that exercise, diet changes, those have absolutely no side effects whatsoever. So feel free to indulge in the dietary changes and the exercise, and it's also free. So at least 2.5 hours a week for exercise. When we're looking at medications, there's a multitude of medications that we can use for diabetes: metformin, DPP-4 inhibitors, GLP-1 receptor agonist, and GLP-1 receptor, GIP receptor agonist, SGLT2 inhibitors, sulfonylureas, TZDs, and then insulin. Looking at the dietary changes, of course, reducing sugars, limiting alcohol, more non-starchy vegetables and whole grains. So we want to make sure that we're getting rid of a lot of the starches, the breads, the baked goods. If we're doing rice and potatoes, we want to make sure that we include portion control. And just really doing things in moderation. When we look at our plate, we want it to mostly be vegetables, honestly. Some lean protein and some starches, but we definitely don't want for our plates to be mostly starches. We want to really layer in those vegetables and layer in some of that lean protein. So weight loss, 3 to 5% can even help when you're looking at that drop in the body weight. So checking the blood sugar, we want to do it first thing in the morning, before eating, 2 hours after eating, at bedtime. And what I really am a big advocate for are people using those continuous glucose monitors. We see commercials about them all the time. They continuously monitor your blood glucose. And a lot of studies have shown that even if you just know your glucose without any other intervention, without other medications, without other lifestyle modifications, just wearing a sensor or a glucose monitor for a lot of patients will drop that hemoglobin A1C on average of 1 percentage point, because you know what the glucose is and you make those appropriate adjustments based on the glucose. So body mass index, or BMI. This is often used to classify weight. So looking at the BMI classifications in adults, normal BMI is going to be 18.5 to 24.9. Overweight is going to be 25 to 29.9. Obese is 30 to 34.9. Obesity 2 is a BMI of 35 to 39.9. And then obesity 3, we consider morbid severe obesity, is going to be greater than 40. So people with the BMI in the overweight range are above above are more likely to have high blood pressure, high cholesterol, and type 2 diabetes. So again, that's where lifestyle modification really does come into play. We really want to make sure that, if we have a normal body weight, normal body habit, is that we keep it. We know that once you gain weight, it's more difficult to lose weight than it is to maintain your weight. So if you have a healthy weight, or if your children have a healthy weight, we want to make sure that we really are making it a goal and making it a point to maintain that healthy body weight. And if that BMI is elevated, if we are in the obese range, then we want to make sure that we're trying to bring it back down. So BMI does have some limitations. We do want to combine it with other measures such as waist circumference. It's most useful to use it, to look at averages in large groups and not just individual patients. The ranges, and when we look at BMI, it was based on Caucasian patients from 1911 to 1935. So a lot different than what we're looking at here in 2023 with the diversity that we see in our population. And it does not account for body shape, makeup across race, ethnicity, sex, gender, or age. And so we can think about, people may have the same BMI. You may be a strong bodybuilder, or you might be someone that's obese, and you could actually have the same BMI. So we really do want to take body composition as a part of it. We don't want to just look at BMI by itself. We do want to take other things into consideration. So it could be better if it was updated, looking at personalized cutoffs based on race, ethnicity, sex, can be used. So when we're looking at the average BMI, when we're looking at African American men, 28, Hispanic men, 28, Caucasian men, 29. When we're looking at women, for Black women, it's 31. So just looking at these numbers here, the BMIs do differ across different ethnicity and gender. So what should we know about type 2 diabetes, cardiovascular disease, and cardiovascular risk? What do African American patients say about diabetes and cardiovascular risk? My mother had high blood pressure, and diabetes happened later in life. It got me thinking about getting more information. The only thing I really know about cardiovascular disease is from my dad. When he had heart issues, I hear it can be associated with diabetes, but I never really dug that much into it. I knew once I had a stroke how cardiovascular disease and diabetes could affect everything and make my life really more difficult to manage. And so looking at all these quotes, these really do emphasize the idea that it's not just about controlling the blood sugar. It's not just about keeping that hemoglobin A1C down and keeping those blood sugars in an acceptable range. It's really about preventing the complications. And when you look at some of the biggest and scariest complications, those are going to be strokes, they're going to be heart attacks, it's going to be those cardiovascular complications that are so dreaded and that are so impactful when it does happen to a person or happen to one of our loved ones. Many of us have seen loved ones who've been devastated by stroke or devastated by heart attack and heart failure and all these things. And we know how much of an impact it not only has on the lives of the person that has it, but then also their family. And they need caregivers, and other people have to step in and help them just get through their their everyday tasks that they have to do. So we know most of us have seen the impact of cardiovascular disease on our loved ones. And many of these things can be prevented with good management, really making sure that we're controlling diabetes and really lowering the risk of many of these complications. So cardiovascular disease, it's really a group of diseases, and this basically affects the heart and the blood vessels. So cardiovascular disease, it includes heart and blood vessel problems. It includes narrowing or blockages of the blood vessels in the heart, the arms and legs, the abdominal organs, and the brain. And when we think about arms and legs, this is what we're referring to, peripheral vascular disease. It can cause abnormal heart rhythms, heart failure, and more. So cardiovascular disease is really a really broad term, but elevated blood sugar, uncontrolled diabetes, it can affect all of these in a negative way. And so these patients or these people are at increased risk of stroke, heart attack, and cardiac death and blood clots due to these complications. So do you have risk factors for cardiovascular disease? So smoking, vaping, type 2 diabetes, the lack of exercise and that sedentary lifestyle, obesity, poor family history, high cholesterol, high blood pressure, all these lead to increased cardiovascular risk. Looking at cardiovascular disease and cardiovascular risk amongst African Americans compared to non-Hispanic whites and non-Hispanic Blacks, African Americans are 30% more likely to die from heart disease, 30% more likely to have high blood pressure. They're less likely to have their blood pressure under control. They're more likely to be smokers, more likely to be affected by obesity. One good thing, less likely to have high cholesterol. But when you look at these disparities in this risk, it really lets us know the importance of this. And it really is an opportunity for us to really intervene, step in, not just for ourselves, but also for our family members to see if we really can try to reduce some of these risks. So reducing cardiovascular risk, it really does require a comprehensive approach. Lifestyle management, blood pressure management. How often do we hear people who say, oh, my blood pressure is always high? Just because the blood pressure is always high, it doesn't mean it's safe. It can be very dangerous. And again, can lead to strokes, lead to heart attacks, lead to renal failure, all these things. So we really want to make sure that the blood pressure is managed. Cholesterol management, blood glucose management, all these things together are going to come and they're going to reduce that cardiovascular risk. So exercise, diet, weight control, reducing alcohol, reducing smoking, all those are going to have a positive impact on that lifestyle. Doing medication, if you need to do medication to keep that blood pressure control, then it's the best thing to do. Many people are so concerned about the side effects of medication, but I always say the side effects of uncontrolled diabetes, uncontrolled blood pressure, and uncontrolled cholesterol are going to be strokes, heart attacks, and death. And so you really want to weigh those options when you don't want to take medications. Lifestyle is going to be very important. Looking at lifestyle modification and medication when it comes to cholesterol. Looking at the cholesterol that's in our bloodstream is not just what our body makes, but it's also what we eat. And so it would make sense to reduce the amount of animal protein and animal fat that we're getting as a means of lowering the cholesterol. Exercising is also going to help to lower that cholesterol. And again, exercise has no side effects and better dietary choices has no side effects. So those are all things that we can incorporate with medications to keep that cholesterol controlled. Blood glucose management is going to be important. So again, GLP-1 receptor agonist, that's a wonderful class of medications that has actually been shown to lower the risk of cardiovascular disease in patients. So medications for diabetes with cardioprotective effects. So these are going to reduce the risk of major cardiovascular events, heart attack, stroke, cardiovascular death. And these are going to be the GLP-1 receptor agonist. They can have effects on risk factors by lowering the glucose, lowering the blood pressure, and lowering the weight. These are all added benefits, wonderful benefits that we see when we have patients that are on GLP-1 receptor agonists. GLP-1 receptor agonists have been on the market probably for at least about 17 or 18 years now. And they've progressed over the years. They've become much easier to use, much easier to tolerate, much easier to take. Many of them are only once a week. And they typically are injectables. There is one oral GLP-1 receptor agonist, but most of them come in the form of injections, and they can be used anywhere from twice a day, once a day, and most commonly now it's going to be once a week. So when we're looking at patient profiles, atherosclerotic disease or cardiovascular patients that are at high risk, overweight or obese patients, and that's going to be many of the patients that have type 2 diabetes or that are at risk for type 2 diabetes. and patients that are at high risk of stroke. So when we're looking at that, so again, we're looking at all the benefits, but whenever we're looking at any medication, we want to look at, we want to look at benefit versus risk. And when you're looking at the side effects that you may have with the GLP-1 receptor agonist, one of the biggest ones is going to be nausea, but that can be easily mitigated by, not eating as much, slowing down with how much food you eat. The way that GLP-1 receptor agonists work in part is because it slows down how fast the stomach empties. And so people feel more full when they take it. And so if they try to eat past that fullness, then they can have some nausea. So I always say that the nausea, yes, it's a side effect, but it's really kind of a warning for a lot of people that you're overdoing it, that you might be eating too much and you need to cut back. Another side effect can be diarrhea. Sometimes patients can also get constipation. Increased heart rate is not something that I see very often in my clinical practice, but it is something that has been seen in studies. Injection site reactions can occur when you're doing the injectable form. It's not something that I see often, but it is something that I have seen in my practice before. But when you look at the overall risk versus benefit, when you're looking at a GLP-1 agonist, there's going to be so much benefit. So many of my diabetic patients that are in my clinical practice, most of my diabetics are going to be on a GLP-1 receptor agonist unless there's a reason not to. And for most patients, there's not a reason not to be on a GLP-1 receptor agonist. And these can include things like Byetta, that's one of the older ones, Ozempic, Wegovy, Trulicity, Victoza. These are all GLP-1 receptor agonists, and they have these added benefits. So the GLP-1 receptor agonist for type 2 diabetes, again, just looking at Victoza, these are looking at the generic names as well as the brand names. Some of these are also approved for weight loss. Again, even when you're treating a patient with diabetes with one of the GLP-1 receptor agonists that's not approved for weight loss, many of them, typically it is expected that you're going to get weight loss, even if you're using a GLP-1 receptor agonist that doesn't have that approval for weight loss. It's just a part of the way that class of medications works. So looking again at another great class of medications for diabetics that have cardioprotective effects. So this is going to be reducing the risk of major cardiovascular events, hospitalizations due to heart failure, cardiovascular death possibly, looking at the effect on risk factors, lowering the blood glucose, the blood pressure, weight loss again, and increasing looking at the increase on cholesterol. It's not something that I really see in my clinical practice often. So patient profiles, who's going to benefit from this? So patients with cardiovascular disease or that are high risk, patients that have heart failure or kidney disease. Many of these have been shown to have positive benefits for patients with kidney disease. It helps to preserve the kidney function. And this is something that's safe for elderly patients because they're not going to typically get hypoglycemic if they're using this type of medication in isolation or using it along with something else like metformin or another medicine that's not going to cause hypoglycemia or low blood sugar. So common side effects are really going to be general infections, yeast infections, dehydration. All these, again, are things that we can mitigate against. I always tell my patients when they're on an SGLT2 inhibitor, it's going to be hygiene. So just making sure that they're clean in that area and making sure that many of them rinse off when they urinate. Because the way that an SGLT2 inhibitor works, it works by actually getting rid of sugar in the urine. And so when you're on this medication, you actually excrete sugar into your urine. And so when you do have sugar there in that area, it's going to put patients at risk for yeast infection. So I always say good hygiene, rinsing off when you're done urinating, hydrating. So just making sure that you're drinking enough water to really flush all that sugar out. And then just adherence to lifestyle modification. So again, not overdoing it with the sweet, not overdoing it with the barbecue sauce and the birthday cake, making sure that we're sticking to that diabetic diet so that you don't have so much sugar in your urine that you're going to get a yeast infection. So looking at this class of medication, it has been a tremendous benefit in my clinical practice. So these are going to be things like Farxiga and Volcana, Jardiance. Those are some of the more popular ones. Teglatro is one of the newer ones. Brenzavvy is one of the newer ones that we see. But these are also very commonly used in my clinical practice because you're going to have that weight benefit. You're going to have that blood pressure benefit. For many patients, you're going to also have that benefit with the reducing the risk of hospitalization for heart failure and improving the kidney or preserving that kidney function over time. So have you been prescribed a medication for type 2 diabetes that lowers your cardiovascular risk? And this is a really important question. When you're looking at racial ethnic disparities in the use of GLP-1 receptor agonists and SGLT2 inhibitors, Look at these numbers. So looking at the GLP-1 receptor agonist, looking at patients that are on them, 28.5% of white patients, 19.8% of Black patients, 21.3% of Hispanic, and 5.9% of Asians. So looking at this wonderful class, all of this benefit, and we see that looking at Black patients, they're only at 19.8%. This is a significant disparity, again, because remember, reflecting back on the previous slides, we're at higher risk for cardiovascular death, higher risk for heart failure, higher risk for stroke compared to our white and Hispanic patients. So looking at this is something that really leads us to understand that this is something that we do need to talk about more. We need, when we look at Blacks and we look at whites, Hispanics, we're all working. We all have good health insurance. There's no reason that we shouldn't be getting the benefit of these better medications. Looking at SGLT2 inhibitors and who's on this and who's not. Looking at white patients, 7%, 4.7 for Black patients, 6.5 for Hispanic, and 1.2 for Asian. So again, very beneficial class. This is a medication that typically almost all of my diabetics are going to be on a GLP-1 receptor agonist or a GLP-1 GIP receptor agonist, or they're going to be on an SGLT2 inhibitor because I see the benefit. I see the benefit when it comes to weight, when it comes to cardiovascular disease, renal disease. When it comes to stroke and heart attack, all these things are important. I emphasize to my patients, it's not the elevation in the blood sugar that gets you. It's going to be all the complications. And layering in an SGLT2 or layering in a GLP-1 is really going to lower that risk of complications. So you should be asking your doctor specifically, if you don't know the classes of medications that you're on, am I on a GLP-1 receptor agonist? Am I on an SGLT2 inhibitor? And if you're not, then this is something that you pursue. You have to be your best advocate because at the end of the day, we're responsible for our own care. So what do African American patients say about medications for diabetes? Doctors don't really talk about side effects that much because they may scare patients away. One of the things that concerns me is that some of these newer medications are good for diabetes, but they have multiple side effects. I really need my doctor to do more testing to make sure that the medicine is working and the dosing is right. So all these are legitimate concerns. But again, looking at risk versus benefit, we know that the side effects of uncontrolled diabetes is going to be stroke, heart attack, and death. When we're looking at the risk of these medications, you may have some nausea if you're on an SGLT2, some nausea if you're on a GLP-1, like Ozempic or Trulicity or Victoza, but when you look at all that benefit, that's going to be minimal. So the benefit of that medication is going to far outweigh the risk of side effects. So again, have those conversations with your doctor. If they do want to put you on a new medication, what are the side effects? How can I mitigate those side effects so that you can still get the benefit of those medications? And in clinical practice in real life, of course, you're going to look at that panel, you're going to see a million side effects that can happen. But for most patients, you're going to be at risk for maybe a couple of those. And even with those can be mitigated and they can really be controlled. Most patients do extremely well with GLP-1 receptor agonists. Most patients do extremely well with SGLT2 inhibitors as well. So do patients take the medications even if they're being prescribed? So less than 50% of patients with type 2 diabetes actually take their medication as prescribed. African American patients are 25% less likely to adhere to their diabetes medications than white patients. This is very important. It could be a multitude of reasons why. It could be that that patients are afraid of side effects, or that they're experiencing side effects, or it's just something that they don't feel is suitable, or they don't want to take the time to do it. But all of these things lead to that higher risk of stroke, higher risk of heart attack, worsening outcomes when it comes to African Americans with diabetes, and the death rate for diabetics who are African American. So what are the reasons that many African Americans do not take their medications and prescribe? Preconceptions of medications, concerns about the side effects, doubts about the effectiveness, and just the frustration about the long-term treatment. My patients always ask me, how long do I have to be on this medication? And I let them know, as long as you have diabetes, the goal is to get your sugars down to an acceptable level. And when you're looking at medications now, it's not just about that glycemic control. We want to lower the risk. We want the risk of stroke. We want to lower the risk of heart attack. Those things are just as important. And so when you're layering in a medication, I think the goal should really be getting yourself to a point that you're not at risk. It shouldn't be, how long am I going to have to be on this medication? It should really be, how healthy can I be knowing that I am living with diabetes on a day-to-day? Looking at the perception of diabetes. Some people don't really believe that they have diabetes because they may not be having any symptoms. If you're having symptoms of diabetes, that means it's really bad. The goal is to catch diabetes before you have any symptoms. That's the importance of regular checkups, regular physicals, and just knowing what the signs and symptoms are. So, accessibility to medications and resources, the unavailability of medications, the lack of resources to help with self management, and lack of knowledge. I live in a predominantly African American area, but my patients are very diverse, and it's very, very common that I will have African American patients that come to me that are not on the newer medications. They're on much older medications, and there could be a multitude of reasons why. It could be the providers or the providers that they have that don't have access to the medications or don't know about the newer medications, or they just may assume that the newer medications are too expensive. So in my clinical practice, I do make it a point that all patients have access to the newer medications because there is such a clinical benefit that I see, day in and day out when it comes to how they do long term. So, what should you ask your doctor about type 2 diabetes and reducing that cardiovascular risk? What do African American patients say about managing their diabetes and partnering with their doctors? I learn more about my diabetes, and I also learn about different things that come from my diabetes, that come from diabetes, that can deal with diabetes through my doctor. I like the team approach. It also helps me with the medication that they provide. Now they can see the whole scope of everything that I take. I get positive reinforcement tools weekly from the clinic and from the doctor. So this is all just really partnering with your doctor. I always say as a provider, I cannot control your diabetes. My job is to give you the best tools available, and it's up to you to be able to use those tools. But really, it has to be a partnership. You have to trust the doctor. You have to be engaged with the whole process, because at the end of the day, it's your health and it's your responsibility to take care of it. So knowing your numbers, knowing that hemoglobin A1C is going to be checked every 2 to 3 months. As I said before, the target is going to be less than 7 or less than 6.5, depending on the guidelines. That BMI, knowing that BMI, looking at waist circumference, looking at that weight, making sure that things are always moving in the right direction or that you're maintaining. Looking at that blood pressure is going to be really important. So I do emphasize that my patients check their blood pressure at home. Bring those logs in when you're going to your doctor so that they can see how that blood pressure is doing, not just when you're in the office, but also when you're at home on a day-to-day, when you're at work. Keep an eye on that blood pressure because it's going to have a big impact on how you do long-term. Cholesterol levels, looking at those lipids. These should be measured at least once a year, sometimes more often if we're adjusting therapy. So again, looking at the LDL, which is the bad cholesterol, the HDL, which is the good cholesterol, and the triglycerides. And all of these numbers are not only affected by medications. Lifestyle modification is also the key. Exercise is going to help that blood pressure. It's going to help that weight come down. It's going to help that LDL come down, help that HDL, which is the good cholesterol, come up, and it's going to lower that A1C. So it's not just about medications. It's also about doing your part and really layering in that lifestyle modification. So what can you do? Talk to your doctor. Ask the questions. What number should I be most concerned about? You should know your hemoglobin A1C. You should know if it's too high. If it was good one visit and elevated the next visit, what did I do differently? What can I change? How can I get that hemoglobin A1C back down? What can we do to get those numbers in target? What else can we do to reduce the risk of stroke and heart attack? Are you on a GLP-1 receptor agonist? Are you on an SGLT2? Is your hemoglobin A1C at target? All these things are going to come into play. Why am I on the medications that I'm currently taking? When I put a patient on a medication, I explain to them why. I explain, hey, this is going to lower your risk of stroke. It's going to lower your risk of heart attack. It may help to preserve your kidney function long term, depending on that medication that I'm putting you on. But I explain to my patients why I'm using those medications, because ultimately they have to buy into it. They have to buy into why this medication is good and why they should be taking it every day or once a week, depending on the medication. Do my medications help me reduce the risk of stroke and heart attack? Are there programs that can help me manage my diabetes and reduce those cardiovascular risks? So these are all points that we should be making with our physicians, having those conversations and really engaging in, caring for ourselves as diabetics, or helping to care for our family members who are diabetics. So other important topics that we may want to discuss. Do they have any advice for staying on medications? Are there any ways that they can reduce, the number of pills? Many of these medicines come in combinations. What can they do if the medications aren't covered by their insurance? For many drug companies, there are resources available for patients who can't afford their medications or who don't have good insurance. Where can I find information and resources for African Americans? How can I meet other people that are going through the same thing? And unfortunately or fortunately, diabetes is everywhere. So many of your coworkers, if you're in school, things like that, many people have diabetes. And so just really getting those conversations going so that you can really be a support system for each other, especially within families, within work colleagues, things like that, amongst friend groups. Diabetes is really prevalent. And so just really being a support system for each other is also going to be important. So what do African Americans say about self-advocacy and staying informed? So you have to advocate for yourself because no one else is going to advocate better for you than you. As patients, we have internet access. And I say, just take that information with a grain of salt. We want to get good information from the internet. We have our healthcare resources, different government sites that break down certain medications and everything that you can get from that information. Do a lot of research, reach out to certain people who who are diabetics, especially if they're doing well. What are you doing? How are you keeping your hemoglobin A1C at target? Which provider do you go to? If someone has a good doctor, then it might make sense for you to switch over to that one if they have a good rapport and if they really do have a good relationship with their patients. So key takeaways. So type 2 diabetes is more common and more likely to lead to complications in African American patients. This is multifactorial as to why. It may be access to medications. It may be access to good information. It could be just the perception of using certain medications when it comes to diabetes. And in some cases, it just could be just the approach that African Americans that we have to diabetes. Well, my aunt had diabetes, my mom had diabetes, I'm going to have diabetes. Those attitudes and that type of thinking really needs to go out of the window. There's so much that we can do before we even get to the diabetes stage or the uncontrolled diabetes stage that we really need to start to take ownership of and take into account. Type 2 diabetes increases the risk of cardiovascular disease, heart attack, stroke, and heart failure. I always tell my patients, you are not going to die of elevated blood sugar. It's going to be strokes and heart attacks. Those are the complications that we really have to be looking out for. Reducing cardiovascular risk requires management of lifestyle, blood pressure, cholesterol, weight, and blood glucose. All these things are going to be important. Lifestyle modification has no side effects. Medications that reduce cardiovascular risk, such as GLP-1 receptor agonists and SGLT2 inhibitors, are highly recommended for patients with type 2 diabetes. Reflecting back on the slides that I saw before, the percentage of diabetics that are on these medications is low. These should really be the gold standard. These should, when a patient comes to my practice, if they're not on a GLP-1 receptor agonist, if they're not on an SGLT2 inhibitor, over the next few visits, I'm going to plan on layering these medications in. I'm going to explain to my patients why it's so beneficial. And they're going to understand that we are really working as a team. We're working as a team to really prevent the complications down the line. I tell my patients, we're not just worried about diabetes for today or for next week. We're really thinking about diabetes and the lack of complications 10 years down the line, 20 years down the line. So you really do want to get a doctor that you can work with, that you can talk to, that you can understand, because these things are going to help you have your best journey with diabetes ultimately. And that's what we want. So now I'm opening it up for questions. Thank you for listening thus far.
Thank you so much, Dr. Fahmy, for a very, very, very detailed and interesting presentation. I did learn a couple of things, and there are a couple of things I do plan to correct. So we are now open for the question and answer portion for Dr. Fahmy. So please do go ahead and put your questions in the web position. I do have one question that came in right away. This is surprising. Dr. Fahmy, the first question, why do African Americans have a higher risk for heart problems if they also have diabetes?
So this is multifactorial. When you look at cardiovascular disease, and when you look at African Americans, and when you look at diabetes, and when you look at cardiovascular disease, and when you look at those risks, So when you look at when you reflect back on the obesity rates, African Americans are going to be more likely to be obese and have those higher BMIs. That's going to lead to increased risk of cardiovascular disease and also increase of having complications for cardiovascular disease. When you go back and reflect on adherence to medications, African Americans are less likely to adhere to medication. So again, this is going to have a negative impact on cardiovascular disease. And it's not even just those two things. When you really reflect on acceptance, I think in our communities, in African American communities, there's a certain level of acceptance that people get sick, we get sick. And I think that perception really does need to change. And a lot of that, we just need to really empower ourselves. You know, when we look at smoking rates, African Americans have higher smoking rates. So there are a lot of lifestyle things that come into play that lead to that increased risk of cardiovascular disease. So when you pair first lifestyle and you compare that along with less adherence to medication, and you combine that with more, all these things kind of come together, and that's just going to increase the risk of cardiovascular disease and cardiovascular complications.
Thank you, Dr. Fahmy. Our next question, what's your first line of treatment for borderline versus diabetic patient?
So I really see borderline and diabetes all really along a continuum. And when I do approach my patients, you know, I have that conversation, you know, with my patients. I let them know, hey, the first thing that we have to do, you know, whether you're pre-diabetes, full-blown diabetes, uncontrolled diabetes, or even just predisposed to having diabetes because of your family history or because you have other risk factors, the first thing is really going to be lifestyle modification. But lifestyle modification meaning, you know, just better and just really detailed instructions on what you need to eat, what you need to not eat, how much you need to exercise, what that exercise should look like, how to create a sedentary work or job or sedentary lifestyle. How do you convert that over to a more active lifestyle? All those things are going to come into play, but depending on the patient and depending on their approach, depending on their goal and where they are along that continuum, that to a degree determines how aggressive I am. If a patient comes to me and their hemoglobin A1C is 5.8, then I might say, okay, hey, we need to go ahead and start layering in this lifestyle modification right now, because we don't want this 5.8 to go to a 6.8 and now you're full-blown diabetes. But how aggressive I am really does depend on my patient and how receptive they are. I often like to treat pre-diabetes with medications because I say no matter how much lifestyle modification we do, there's always going to be an uphill battle. And so if a patient is open to being on therapies early, whether it be metformin, whether it be Jardiance, whether it be medications that are going to not only help that glycemic control, but also help to lower that cardiovascular risk in early diabetes. And for many patients, if they're still in that pre-diabetic range, you know, even just layering in an insulin sensitizer, sometimes, you know, using an appropriate GLP-1, if they're overweight or things like that, all those things can be done. It just really depends on how open the patients are and what their goal is. You know, many patients say, oh, well, my goal is to not be on medication. I let them know your goal should really be to be as healthy as you can be for as long as you can be, regardless of if that means medications or not medications. So a very, very long-winded answer, but really it depends on the patient. Depends on where they are along that continuum. It's very common that I'm going to put them on an insulin sensitizer. I may put them on a GLP-1 if it's the appropriate patient. I might put them on an SGLT2 if it's an appropriate patient, depending on where they are along that continuum, you know, from normal to just, and even insulin resistance, even when we think about before that so this is like the pre-diabetes. For many of my patients, if they come in, if they're having weight issues, if they have a strong family history of diabetes, if they have what we call acanthosis nigricans, this is just a sign of insulin resistance. Many times I'm going to measure their insulin levels. If their insulin levels are elevated, then I already know that insulin resistance is there. And so it might make sense to put them on an insulin sensitizer before they're even to the pre-diabetes range. So it just really depends on the patient and depends on how open they are. I am a huge fan of lifestyle modification, but I'm also a huge fan of the right pharmaceuticals and the right patient.
Thank you, Dr. Fahmy. What are the risks of taking an SGL2 inhibitor with metformin?
So this is commonly used together, and these two medications work differently. Metformin is an insulin sensitizer. It helps that insulin to it helps your body respond better to the insulin. It helps that glucose to actually go into those cells and go into those tissues. When you're looking at an SGLT2 inhibitor, so what does this do? So in normal patients, in any person, when we're forming urine, have a lot of glucose in our urine initially. And then towards the end of the collecting ducts in the kidneys, when we're forming that urine, all of that glucose gets sucked back up into the bloodstream. So the SGLT2 inhibitor, it actually prevents all that sugar from being sucked back up into the bloodstream and taking it out of the urine. It leaves that glucose in the urine. And so that sugar in the urine actually leaves the body. And so when that sugar leaves the body, your body needs less insulin to management because the sugar is literally gone down the toilet. And so these two medicines work very differently. When you are on an SGLT2 inhibitor, what are going to be the side effects that we think about? We're going to think about, we want to make sure that the patient is well hydrated. We want to make sure that they're not what we call volume depleted or dehydrated. So we want to make sure that they're drinking enough water. When we're looking at patients, whether it be male or female, but especially female, again, because that sugar is in the urine, they may be at risk for having yeast infection. So again, flushing all that glucose out with hydration, hygiene, so just really washing that area, and then just adherence to the lifestyle modification that we want. And then, just when you're looking at an SGLT2 along with metformin, metformin has its own, side effects. The biggest one that you're going to see with metformin is going to be sometimes some stomach upset or maybe more frequent bowel movements. And so when you look at both of them together, metformin has its own set of side effects. For most people, it's pretty well tolerated. And the SGLT2s have their own, set of side effects. But again, it's pretty well tolerated. So the biggest things for both of them is really going to be adherence to diet. That's actually going to help with the GI side effects that you may have with metformin. And it's going to help with the urinary side effects that you may have with the SGLT2. So these medicines come in combination very commonly. There's one called Synjardy, which is Jardiance and metformin together. There's Zigduo, which is Farxiga and metformin together. And then you have this other one called Stegluromet, which is Steglatro and metformin together, and Invocamet, which is Invocana and metformin together. So there's a reason that they put all these medicines with metformin. They're used in combination really well. They work well, and they're relatively well tolerated. So the biggest thing is going to be just make sure that you're staying hydrated. With metformin can deplete you of your B vitamins. So I always suggest that patients be on a multivitamin or a multi-B complex if they're on metformin.
Thank you, Dr. Fahmy. Let's see. In conversation with people that have stated that they were cured from diabetes through diet and exercise, in speaking with professionals, I've been told that people aren't cured, but the diabetes is being managed. What are your thoughts?
So again, no diabetes, pre-diabetes, well-controlled diabetes, uncontrolled diabetes, it's all a continuum. Diabetes is, again, reflecting back to those glucose numbers that we talked about. So if the sugars are normal, if they're not in the diabetic range, then technically you no longer have diabetes, but you still may have the preponderance for diabetes. And so I always say, so even for my patients, the diabetes can be quote unquote cured. I can have a patient come in, their hemoglobin A1C can be 9.8. This is really uncontrolled diabetes. This is poorly controlled diabetes. I can put them on a GLP-1 receptor agonist once a week. I can put them on, Jardiance or another SGLT2 every day. I can put them on metformin. I can get that hemoglobin A1C down to 5.6. 5.6 is normal. Now they're on medications. Their diabetes is really well controlled, to the point that they're not even in the diabetic range. So as a provider, am I going to stop those medications and allow their blood sugars to go back elevated? Conceivably, I could. Conceivably, I could say, okay, well, let's just stop the metformin, or let's just stop the SGLT2, and let's just see if you can still stay at target. Maybe they would be able to be at target. But again, reflecting back on diabetes, reflecting back on that increased risk, do I want to lower that risk of stroke, lower that risk of heart attack? Do I want to keep that weight control? Do I want to continue to have that positive impact on the blood pressure? Yes. So I'm going to have that conversation with that cured diabetic. And I'm going to say, okay, the writing's on the wall. Yes, the diabetes is better. The diabetes is well controlled. And we're going to have that conversation about whether or not they only maintain that with lifestyle modification, or if it makes more sense to maintain that with medications that are going to have that beneficial aspect, when it comes to lowering the risk of stroke and heart attack. So when you're looking at it, can someone technically be cured from diabetes? Yes, their blood sugars can be in normal range. If they can keep them in normal range, well within normal range, that means even during Christmas and Thanksgiving, your sugars are still going to be in normal range, great. But unfortunately, that's not the case for a lot of patients unless they really, really, really adhere to those lifestyle modifications. If they can do that, I'm a big fan, but always still looking at that hemoglobin A1C every 3 months to make sure that it's not creeping back up, and understanding that staying on a pharmaceutical, staying on metformin, staying on a GLP-1, staying on an SGLT2, all those are going to keep you normal longer. And so even if those sugars are in normal range, it still might make sense to let's just stay on these medications, because it'll keep me from going back into that diabetic range later on into the future. Again, it's not just about today, it's about 10 years from now, 20 years from now.
Thank you, Dr. Fahmy. Is there such a thing as hereditary when it comes to diabetes?
Absolutely. Diabetes runs in families. There are certain genetic components. And if you do have a strong family history of diabetes, you're going to be at risk. So that's, again, reflecting back on that pre-diabetes. If both your parents have diabetes, then you probably have pre-diabetes. Even before the numbers are elevated, you're already predisposed. And when you think about that idea of being predisposed to diabetes, it's not just about the genes. It's also about the lifestyle. If you have two parents that are diabetics, more than likely that lifestyle that they have is going to impact you because you have a similar lifestyle. So again, lifestyle modifications or lack thereof is really going to have an impact on a person's likelihood to develop diabetes. So it's not just the genes, it's also what's going on in that household. So yes, there's a genetic component, and even not just a genetic component, also the idea that many of them share a similar lifestyle, which might also predispose them to getting diabetes.
Thank you. This comes from a gentleman in the audience. My A1C is between 5.75 and 6.0. Should I be concerned?
Absolutely. Now, number one, you should already be making lifestyle modifications, eating better, working on getting that hemoglobin A1C down even lower if you can. And again, depending on that relationship that you have with your physician, depending on your age, depending on other risk factors, depending on whether or not that A1C is trending towards up or if it's trending downward, it may be time to layer in something to keep you in that early pre-diabetic range rather than allow it to gradually creep up. But that's going to be a conversation with you and your physician. That's going to really depend on, your other risk factors. And it's going to depend on how open you are to being on pharmaceuticals. So again, with my patients, I can go either way. If a patient just wants to be monitored and they're going to really be intensely engaged with that lifestyle modification and those A1Cs are good, I'm happy to watch, encourage, and monitor. And if that A1C does creep up outside of what I consider acceptable or they consider acceptable, then we intervene with pharmaceuticals. So it really just depends on the trend, depends on you as a patient and what you're open to and what your goal is. Again, and the goal is really, really to prevent complications down the line, prevent that diabetes from going to real diabetes. Even if it's 10 years from now, 20 years from now, then it might make sense to layer in a therapy depending on again, how long it's been going on and what the other factors are.
Thank you. What is your opinion about keto or other low carb diets? What about intermittent fasting?
So when you look at intermittent fasting, a part of the reason that intermittent fasting works is because your body's not taking in any starches. Those starches are not being broken down into glucose, and your body doesn't need to make as much insulin during that interim period. So it kind of gives your pancreas a little bit of a break. And so whatever reserve that it still has, it can better utilize that, and it can keep the blood sugars better control. When you're looking at keto, you have to look at the quality of the foods that you are taking in. I have never been a fan of large amounts of animal fat or animal protein in a means to try to improve diabetes, because again, Diabetics, they don't die of high blood sugar, they die of strokes and heart attacks. And when you think about, when you think about animal protein, when you think about high fat, when you think about butter and other things like that, that might be a part of that type of diet, then you really want to be careful. So the biggest thing is that regardless of the type of diet plan that you get on, you want to make sure that your provider is monitoring your glucose, but also monitoring that cholesterol to make sure that cholesterol is not getting too high. And if you do want to do a different diet, you really want to make sure that it's being impactful and make sure that it's something that you can sustain. Getting on some really intense diet and losing 15 pounds in 10 weeks and everything being great, if it's not sustainable and then you just fall off the wagon and go back to eating what you were eating now, instead of 15 pounds, you're 20 pounds up, that's not what we want to do. We want to, choose whatever diet that you have, or whatever, I don't even like to call it a diet, whatever lifestyle or dietary lifestyle you have, you want it to be sustainable. You want it to be something that you can continue to do, so that it's not this up and down ballooning, up and down with your weight. So the biggest thing is to make sure that it's sustainable. Many of the different weight loss and dietary programs work, but you want to make sure that you're being monitored and make sure that it's having a positive impact when it comes to your overall.
Thank you. Thank you so much. I'd like to thank everyone for joining us this evening. We really appreciate Dr. Fahmy being here. We thank ACHL and all those that made this tonight's event possible. Couldn't have had better engagement. And thank you for joining us this evening. Good night.
Thank you.